It's a pleasure to be here with you today, and I'll be talking a little bit about the area of research that focuses on religion and spirituality. And I will say that I came upon this research in some ways by accident, in that I was doing research down at Emory University in Grady Hospital, asking patients and family members about how they make medical decisions and also how they cope with serious illness. And patients again and again brought up their religious faith. It was probably prominent for a couple of reasons. One is that the South is certainly sort of the center of the Bible Belt, and there were very religious people. But also in the South, religious talk is something that's very common. As my time went on and I moved up here, I realized I sometimes have to query people a little bit more deeply to ask to get to those issues. And the second thing I've learned over time is that religious patients will bring up these things in a more overt way. Everybody has similar questions about meaning, purpose, and value. And these questions come to the fore when people experience life-threatening illness or death. And that's led this to be an important part of my research. So before I dive into specifics, I just want to talk about my team. And of course, this is interdisciplinary work and requires colleagues from all over campus, which is just a joy. So I have a team here at IU CAR. My research team is absolutely fantastic. We work I direct the Evans Center at IU Health, which focuses on research in religion and spirituality. And then we collaborate closely with the Fairbanks Center for Medical Ethics and the Spiritual Care and Chaplaincy Services Department at IU Health, and could not do this work without these close collaborations. So in the next 20 minutes or so, I'm going to talk about religion and spirituality in the healthcare setting to kind of give an overview and background. I'll talk about the state of research nationally and internationally on spiritual care interventions, and then talk a little bit about the work that we're doing here. So again, I started by observing specific things about the religious experiences of some of my patients. My framework has broadened to think more broadly about spirituality. And there's an international consensus committee led by a woman named Christina Puhalski, who's a physician at George Washington, that defines spirituality as a dynamic, intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationships. So spirituality is expressed through beliefs, values, traditions, and practices. I think what's important about this definition is that it is inclusive of really all human experiences. So everyone seeks meaning in the things that happen to them. Relationships are important. The significant is important, whether or not you regard it as sacred. And these things come to the fore in life-threatening illness, really for everybody. Religion, on the other hand, is something more specific, and that is a set of particular beliefs, practices, texts, and other features that are related to this concept of spirituality. So religion is much more focused. I think an important thing to note in the United States is that a growing proportion of people would define themselves as as spiritual but not religious. And I think that I recognize in my work that people manifest their spirituality in all kinds of different ways. I'll also acknowledge that some people would not call themselves spiritual and might actually take issue with my defining spirituality as a universal trait. And so I want to acknowledge that there are even maybe some of you in the room who don't really buy the idea that everybody is spiritual. So research on spiritual care, why do it? I think that all of us are called to use the scientific method to improve patient care. We do this in all kinds of ways. And one aspect of patient care is addressing these broad spiritual concerns. And that's why I'm passionate about this. We can understand how to improve the spiritual care that we deliver in our health systems by chaplains, but by others as well. And I also think it's important to demonstrate the effectiveness of addressing spiritual concerns in the healthcare setting. Areas of focus of research include religious and spiritual support, chaplains' practice, and the effect of spiritual care on outcomes. And that is a specific one that I'm going to be focusing on today. When I first gave a talk at an IUCAR WIP about this topic, a colleague stood up and said something really interesting to me. He said, every time you talk about this stuff, I feel guilty because I'm not religious. And I'm really afraid that you're kind of judging me for not being religious. And it really gave me pause. He explained a little bit about his background and how religion had actually been kind of a negative force in his life. And so I just want to acknowledge that some people find this work uncomfortable. Other people have resisted this work for other reasons. One is they're worried it's going to advocate for a particular religion or for religions in general. And another objection is that spirituality and religion is something that's kind of ethereal or deeply personal, and that it can't be put under a microscope. I would argue that many of the things we research, particularly in the social sciences, are things that you, quote, can't put under a microscope either. Things like opinions, values, depression, anxiety. We have come up with rigorous methods to evaluate those things. And so I think we can have rigorous methods to evaluate religion and spirituality as well. Another objective is that we're imposing the scientific method and that it's in conflict with the individual responsive nature of spiritual care. And this is a concern that's come from chaplains who often will go into a patient's room with literally nothing in their hands, no preconceived notion about what's on that patient's mind and what they're going to want to talk about, including, by the way, no particular sacred text. So they're not assuming that the patient has any particular religion. And when we do behavioral interventions, of course, we need protocols that can be replicated in future studies. And so there's this balance, and those things are genuinely in tension. So I hope I've convinced you of why this is important. I now want to go ahead and talk about the role of religion and spirituality in illness. And I think that it serves at least several roles. Illness is a spiritual crisis. We use spirituality and religion to cope. Spirituality and religion are important in decision-making. And finally, in the healthcare setting, because of all those things, there is an important need for spiritual support. So is it really a crisis? This was a study, a qualitative study that I thought had some beautiful quotes that kind of illustrated how an illness can be a spiritual crisis. So this one person said, "I felt scared and thought I was probably going to die. This made me think seriously about my life. What had I done to deserve this?" So a huge question about meaning. Why do things happen? You know, in the classic book, why bad things happen to good people? This is called The Odyssey. The question of why evil exists in the world is something that can come up in the setting of illness. Another quote, "The whole thing has awakened in me, stirred in me religious beliefs, a whole reappraisal of life." And this can happen with a life-threatening illness as well. Another important theme is religion and spirituality as a source of coping. This was a study that we did at Grady Hospital. We collaborated with the director of chaplaincy, Robin Brown Haithco, and this was one of our quotes. "I know that without faith, I couldn't have come this far. Faith is very important to me because of the simple fact that without faith, I probably wouldn't be here right now, without hope and faith and trusting in the Lord." So for this particular individual, faith was what got them through in a chronic serious illness. One study that was done in psychiatry found that 80% of persons with serious mental illness in Los Angeles used religious activity or belief to cope, and 30% reported that it was the most important thing that kept them going. So for at least a subpopulation of people, this is tremendously important. So I hope I've established that it's important. The next area that I think is really interesting is the impact of religion on end-of-life preferences and treatment. So this is another area that I think is really worth digging into. A number of studies were done early on that interviewed patients about their religious and spiritual beliefs and then looked at treatment. So an early study found that patients who endorse growing closer to God during illness want more aggressive treatment. A study by Phelps et al. Looking at cancer patients found that patients' religious coping impacts the aggressive care that they receive at the end of life. So not only the care that they want, but the care they actually get. We published a study recently that found that surrogates who believe a miracle might save the patient are less likely to prefer a DNR order, and the patient is less likely to receive hospice care at the end of life. So miracles seem to be particularly important. So based on reviewing this data, there is evidence that patients and surrogates who are more religious tend to want more life-sustaining treatments at the end of life. So that's kind of a preliminary general conclusion. I want to dig deeper into that data for just a minute and make a couple of important points about it. This top table you see is from the Phelps study. And I think what's important to note is that they measured religious coping, positive religious coping. So an example of that would be when I'm feeling stressed out, I pray, or I trust in God to help get me through this. And so they divided their sample into high religious and low religious copers. And as you can see where that circle is, intensive life prolonging care was higher in the high versus low religious copers. And this was significant in their adjusted analysis as well. And this is of patients who died. I think one really important thing I want to point out is if you look at that circle, you'll see that Even of the high religious copers, only 13.6% actually received intensive life prolonging care at the end of life. And so I think a really important thing is that even though there may be these associations, the vast majority of high religious copers did not receive aggressive life sustaining care at the end of life. If you look down at this bottom graph, this is from our surrogate decision makers study, whoops. And I think the important thing I want to point out is that when you look at receipt of hospice at the end of life, we also found an association with religion, but only with belief in miracles, belief that divine intervention or a miracle would save the life of a patient. So it is not just being religious on the part of the surrogate that influences whether the patient goes to hospice, it is this particular belief. And I think that's important. Religion is diverse and multidimensional. So we shouldn't think of it all as this unitary construct. We found that patients, when the surrogate believed in miracles, and a miracle might save the patient, they were substantially less likely to enroll the patient in hospice at the end of life. So patient and surrogate perspectives, we found that themes of acceptance of death and struggle against death are both important concepts. So here's someone who says, I don't actually fear death as I did in the past because I know that's a deliverance. Death is a deliverance. So accepting death based on faith. And someone else who was talking, who says, my mother did not want extraordinary means. She wanted us to go so far. And then after it was God's will, let God take over. So in this case, doing God's will requires that you avoid extraordinary means. There was an interesting study that looked at ethics consults and life-sustaining treatment decisions, and they actually found that religion was present in 3 ways, some of which I've talked about. One is that they talked about coping. The second is they talked about chaplaincy visits, and the third is that it was central to conflict about life-sustaining treatment. And I think what's important here is that it was central to conflict in only a quarter of the time. It was actually much more commonly mentioned as a coping mechanism. And so I think that's just an important thing. And also they found in this small study that religion was not associated with in-hospital death or receipt of life-sustaining treatment. So just another thing to kind of confuse the picture about the role of religion in treatment decision-making. So moving on to spiritual and religious support. So we know it's important. What do we do about it in the healthcare system? Here's a quote that from a study that talked about kind of the role of religious and spiritual support, in which a patient said, the nurse at night allowed me to cry. She remained with me, just sitting by me. I felt accepted that way. I remember she did say I could speak to the hospital chaplains if I wanted to. The day staff would organize it for me. The chaplain did visit me and I did find it helpful. My own pastor and church friends visited, and of course this was most helpful of all. So basically, spiritual support can be provided in a variety of ways by a variety of different staff members, including sometimes nurses, doctors, and others, but particularly the chaplains. So another report from this Coping with Cancer study found that 88% of cancer patients consider religion to be at least somewhat important, but 47% reported their spiritual needs were minimally or not at all supported by their religious community, and 72% reported they were not supported by the medical system. So even though this is important, we're really not reaching many people with this kind of support. So what does chaplain support look like? We have some quotes from our studies that show kind of what this is like. And this particular quote is from a surrogate who said chaplains came by and prayed with her at times. God's healing touch was instrumental in her getting better. And also, you don't only ask for prayer for the patient, but you ask for prayer for the family as well, because it was a really hard time. So I do want to talk specifically about the role of chaplains. I will tell you that I did not know much about what chaplains did early on in my career. I was at a conference in Wisconsin, and we took this trip to Taliesin, the Frank Lloyd Wright home, and I sat next to a chaplain who spent the whole trip explaining to me what chaplains do. They treat people of all faiths and no faiths. They don't make assumptions. They're not there to proselytize. I was just sitting there with, this look of awe on my face. I had no idea. I just basically thought they came for codes and deaths and prayed with people. But that is a really narrow view of what chaplains do. So I'm glad I learned that early. They are the spiritual care expert in the hospital. There are 10,000 healthcare chaplains in the US who provide 10 to 15 million hours of care each year. Hospital chaplain staffing varies widely from maybe having a couple of volunteers or nobody at all to having a well-staffed chaplaincy department, and in fact training programs, and they do internships and residencies similar to physician training. They are trained to comprehensively assess spiritual and religious needs of patients, families, staff, and address those needs, and that's what they do. I won't read you all of their competencies. It's actually a very long list, but just to kind of elucidate a few, they establish, deepen, and and end pastoral relationships with sensitivity, openness, and respect. They manage crises. They use spiritual assessment to contribute to plans of care. They provide religious and spiritual resources. And finally, they facilitate theological reflection on the practice of pastoral care, something that they're uniquely qualified to do with patients. Let's see here. I feel like I've seen that slide before. So now I'm going to move on and talk about intervention research. And so I think I've showed you some descriptive research that talks a little bit about the role of religion and spirituality, but as many of us have done in our work, we now want to move on to finding out what can we do about it. And that's where my research in this area has been going. I think what's important is that this field of research is extremely early. There are a couple of important systematic reviews that have been published in the last several years that basically found 3 high-quality studies of chaplain interventions, only 2 of which were in hospitalized patients. I'll mention a couple of those. One looked at COPD patients, and it was only 49 hospitalized patients. And they found that daily visits led to lower anxiety and higher satisfaction with care. Another one of these early studies was done actually at Methodist Hospital by an earlier position that we have called the research chaplain. So this guy, Paul Bay, enrolled 170 CABG patients, which is coronary artery bypass surgery, and did 5 structured visits and found improved positive religious coping and reduced negative religious coping. And I've mentioned positive religious coping. Negative religious coping is a belief, for example, that when a bad thing happens to me, I realize I'm being punished by God. So that was reduced, that negative religious coping was reduced by this study. Karen Steinhauser, who's a leader in this field, has done a series of studies looking at caregivers of patients with advanced cancer or ALS. And they did 3 chaplain-led sessions by phone. The qualitative results showed a lot of value, and they just completed a randomized controlled trial that compared caregiver outlook, relaxation, meditation, and usual care. The main thing they found is that there were differences. So this study basically shows baseline on the left, and then 5 weeks and 7 weeks. And there was some effect on preparation for death at just their 5-week analysis, but it went away by the end of the study, and no effect on anxiety or sense of peace. So one study, unfortunately, didn't show a result, but an important and well-designed study. So I now want to move on to talk about a study that we're in the middle of here that we're calling the Chaplain Family Project. So as many of you know, I'm really passionate about how families experience serious and critical illness, particularly in the hospital setting. And so we designed a study to explore this. One thing that's really important in this work is that in order to develop an intervention, you need an interdisciplinary team. And we particularly need expertise from the chaplains. We just couldn't have done it without them. So we met regularly over several months with chaplains, healthcare leaders, physicians, and research staff, and developed and reviewed the intervention. We pilot tested, this is a little out of date. We have actually now well completed our pilot test, and then we refined it with feedback from the team. And so our framework, we called the Spiritual Care Assessment and Intervention Framework. We have not only a cool name, but we have a cool graphic, thanks to Phil Lofton. It involves proactive contact, semi-structured assessments, spiritual care interventions, and documentation. So first of all, because it's family members who are in and out of the ICU is where we designed this, we decided that contact had to be proactive. You guys know that family members come and go from the ICU. They're often hard to find during the day, and they might miss the daytime chaplain, and at night there's just a chaplain there for emergencies. So we had our chaplains reach out and contact them. The goal is 3 times, and then once a week until they're discharged, and a bereavement call if they need it. We do this semi-structured assessment, which I'll now talk about. And again, trying to balance that openness that's important to chaplains with the structure that we need in order to have a rigorous, reproducible intervention. So we identified, together with our team, dimensions of spiritual experience, meaning and purpose, relationships, transcendence and peace, and self-worth identity. And then we developed questions for each dimension. At the initial interview, we want the chaplain to ask 1 question or address each dimension, and then in subsequent interviews, they can focus on 1 or more depending on where the patient leads them. So this is a copy of the little card that we send them into the room with. So they start out, again, this is semi-structured, so we ask them to ask at least 1 of these questions, but then take the conversation wherever it may go. We then have the chaplain note the interventions that they do, which might be religious, such as prayer, or things that are more secular or spiritual, such as life review, counseling, normalization, saying, I understand, it's normal for people to feel bad when they're in a situation like this, and then referral to other clergy or spiritual support if they need it. They then document some chaplain support outcomes, such as experiences greater clarity about the meaning of life and other things like that. So we conducted our pilot study in 2 intensive care units at Methodist Hospital. We had a primary study chaplain and 2 other volunteers. We had 25 legally authorized surrogates for critically ill adults. And we were pretty successful in getting this done. 24 out of 25 had the initial in-depth visit. The 25th patient died almost as soon as enrollment was complete. We had 45 follow-up visits and 11 bereavement calls, and we found people were really happy with this. As you can see here, everybody strongly agreed that the chaplain supported them, and they'd recommend it to other family members. Nobody felt contacted too often or bothered, and they all felt supported spiritually and emotionally. So what did they tell us? They prayed over me, they talked over my sister, talked about our religion, and they were very supportive of me. That says a lot. We didn't have that experience 4 years ago with our mom, but we had so much with our sister, and I love that. Here's another one that I thought was great. The chaplain met me in the hallway and stopped me from going in the room, and they were trying to resuscitate the patient, so I didn't walk in on that. I was appreciative of that. And then when my loudmouth granddaughter came in and said, I'm an atheist, I don't need the chaplain, I just told her I do. And he just kind of looked at me. He wasn't frightened off. So things went well there. We're now refining the framework by interviewing chaplains around the state to see how they perceive the framework, and I'll skip these. And now we're doing a randomized controlled trial of 160 patients currently in 4 ICUs, and we are currently just past the halfway point, which we're very excited about. I'll briefly mention 2 other studies that have gone on here. One was led by Sunita Maiko, who sadly has left IU, but he used this framework in cancer outpatients, which I think is important because there are so many patients with cancer, in the next slide, ALS, who never get admitted to the hospital through their whole care, even from diagnosis to death. And if we don't provide spiritual care in the outpatient setting, they might never get it. And then Kate Kaczynski led a study of ALS patients and their caregivers. So to summarize, we're in the early stages of interventions, but I'm really excited about the future. I think next steps are multi-center trials. I really think the time is right for federal funding for these grants. I had the Miracles paper that we did was part of my K-24, and I really wondered if we'd get some resistance, but actually it was reviewed very positively. And we're now developing national networks of researchers, continuing to train chaplains in this, in the field of research so that they can conduct their own high quality research and then implementation of trial results in the clinical setting. So I'll stop there and see if you guys have questions. Yes.
Lexi, is there anything that has been shown? I mean, you touched upon this a little bit regarding some of the bereavement work, but any kind of intervention for caregivers that is sort of spiritual or religious based that seems to have an impact on post-death of the care recipient?
Yeah, so I would say that, again, that is very early in the stages of development, but we are going to be looking at that. I mean, we're looking at the psychological outcomes of the caregivers. And the Steinhauser study looked at that as well. So they did interventions. Well, I mean, I think that they looked at preparation for the patient's death. I think that, yeah, bereavement is a really important concept. And I think our hope is definitely that the coming to terms process that goes on will be something that is a positive outcome of spiritual care interventions. But I'd say, kind of like with these other outcomes, there's extremely little research on looking at the actual outcomes of spiritual care. Susan.
Lexi, I'm curious, having worked with chaplains in the past and kind of understanding their resistance to a lot of structure, how the guide has been received, and then how you think about monitoring fidelity in that context.
Yeah, that's really important. So what I would say is that the key to getting buy-in was definitely partnership. We have been very fortunate to have several chaplains who were part of our process of development. We went to the chaplain department meetings and got initial feedback on the guide. We're most of the way through a study where, again, we asked them to use it with 3 patients and then give us feedback, and we then modified the guide based on the feedback. And so I think that through a process of partnership, we have been able to get buy-in in that regard. And I think, so I think it's been very positive. At IU Health, they are passionate about research. In fact, Kelly Mathis, one of our chaplains, is planning a conference in, I think it's in February, that's about spiritual care research. And it's going to be like an 8-hour conference for chaplains from all across the state. And we have our chaplain researcher, Vern Farnham, has decided that we're going to become the premier spiritual care research department in the country, which I'm super excited about. So I feel like we're in a good place for this kind of thing. And then realize that some of our chaplains just don't like it, and they don't have to do it. You know, we do not make them do it, but I think that we've actually gotten, I think there's a change in the field in terms of being open to this kind of thing. And from their perspective, I think it comes from a couple things. One is that medicine, as it grows increasingly evidence-based, the chaplains, unfortunately, like many of the other hospital services that don't bill, I feel like they're always on the chopping block at budget time. And so how can they show that their outcomes of their care matters to patients, families, and impacts outcomes? I think that's an extremely important project for them right now. And then just the idea that they can use science to improve the care that they provide. So. All right, thank you very much.